Welcome to Beat Cancer, the official podcast of the UC Davis Comprehensive Cancer Center. Thanks for joining us today as we have in-depth discussions of the science, research, and advancements taking place at our National Cancer Institute designated Comprehensive Cancer Center. We will also examine proactive approaches to cancer prevention and, most importantly, how we are breaking barriers to beat cancer in our community and beyond. I'm your host, Chris Joyce, and today we're talking about prostate cancer, and we're speaking with Dr. Mamta Parikh, and Dr. Parikh is a medical oncologist and assistant professor in the Division of Hematology and Oncology, specializing in genitourinary malignancies that also include prostate cancer. So thanks for joining us today, Dr. Parikh.
Thanks for having me.
Outstanding. Well, just to kick this off so that we have a basis of what we're going to be discussing, can you tell us just some of the signs and symptoms that people might be on the lookout for as regards to prostate cancer?
Yeah, I think that's a great question to start out with and really outline some of the difficulties with diagnosing prostate cancer. Because the signs and symptoms of prostate cancer are really difficult to distinguish from the normal signs and symptoms that come with aging for men. So common symptoms that men report when they are diagnosed with prostate cancer include an increased frequency of urination, especially at night. And those symptoms are very similar to things that happen with men as they get older, because it is normal for men's prostates to enlarge as they get older. That's a condition called benign prostatic hypertrophy, which is not a cancerous condition and also leads to increased urination or difficulties with urination. When prostate cancer becomes more advanced, people can have more symptoms. Typically, patients can present with bony pain that's persistent and is not on and off, or they may have unexplained weight loss. And again, bony pain can be very difficult to identify as a warning sign because as we get older, we have more aches and pains. And so oftentimes these symptoms are very insidious and people don't realize until the cancer has become more advanced. Still, I encourage men to follow up regularly with their doctors and be honest with the symptoms that they're having so that things like this could be caught and investigated.
When you mention bony pain, is that kind of like just in your bones or like arthritis type of symptoms?
That's the challenge, is that it can mimic arthritis. People, unfortunately, if they've lived a good long life, they will eventually develop arthritis in the bones. And prostate cancer likes to spread to the bones. So when patients develop cancer that's spread into the bones, they will have pain in the bones, which initially can seem like arthritis. The difference between arthritis and cancer pain is that usually arthritis pain is intermittent. It's not constant. In particular, cancer pain is often described as pain that wakes you up out of night and out of sleep. So those are kinds of symptoms that are particularly worrisome and should be investigated.
Gotcha. Okay. Well, are there biological or genetic markers that could be indicators that somebody might be at risk for developing prostate cancer later down the road?
That's another great question. So this is a field that we've been able to understand a little bit better in the last decade. As many people may be aware, there are genetic mutations that are associated with breast cancer and ovarian cancer that have been in the news a lot. These are mutations called BRCA1 and BRCA2 mutations. These used to be associated strictly with breast and ovarian cancer and were really focused towards screening for women. But in the last decade, we have determined that there are prostate cancers that present with these BRCA mutations, and they can be inherited. So if there is a family history of prostate cancer or breast cancer or ovarian cancer in the family, that can be a reason to screen for that mutation. The presence of that mutation does put patients at an increased risk of developing prostate cancer, not as increased a risk as women who have this mutation have towards breast cancer, but still a real risk. And this is a new thing that we've discovered in the last decade, and we now do a lot more screening for that. And then in terms of biologic markers, we can talk a little bit more about the prostate-specific antigen. This does not necessarily correlate to being at risk of developing prostate cancer, but it is a screening marker. So it really gets into screening, which we could talk about.
Yeah, that sounds great. I mean, first off, it sounds like there is screening that is available. And who should be screened, when, at what frequency, anything like that, please let us know.
So this is a particularly controversial question in prostate cancer. So the prostate-specific antigen marker is a simple blood test, and it's been available for decades as a potential tool to screen for prostate cancer. But the PSA, or prostate-specific antigen, can be elevated for reasons that are unrelated to cancer. So you have what are called false positive results that can be found. For that reason, when this marker was looked at in 2008, the U.S. Preventative Task Force actually recommended against PSA-based screening for men that are 75 years or older. And in 2012, they actually recommended against PSA-based screening for all men with prostate cancer. In 2018, they then switched those recommendations back to involving shared decision-making between a healthcare provider and the patient on PSA screening for men aged 55 to 69 years old. Now, on the other hand, the American Urologic Association and American Cancer Societies this whole time have continued to encourage the use of routine PSA testing. The American Urologic Association has been firm about recommending routine PSA screening annually in men aged 55 to 69. And the American Cancer Society recommends screening in men over the age of 50 as long as they have a 10-year life expectancy or longer. So there's a huge amount of variability with these recommendations. The thing to take away from all of this is that it's really important to have a discussion with your primary care doctor if you're over the age of 50. One of the really important things to hone in on is whether you have an increased risk of developing prostate cancer. We talked about these mutations that may run in your family, but the other thing that's important is if you have any family history of prostate cancer. Even without the presence of BRCA mutations, men who have family members with prostate cancers, a brother, a father, grandfather with prostate cancer, have an increased risk of developing prostate cancer. And those are the men that really should take PSA screening seriously because we would want to capture potential development of prostate cancer as early as possible. For patients that are older, they need to weigh the risk of biopsies, potential surgeries, versus the other medical problems that they may have and whether they could withstand that kind of treatment.
When discussing with like your primary care physician just about the screenings or blood test or anything like that, is genetic testing or hereditary testing also something that comes into play?
Yes, so genetic testing can definitely be considered, again, for anybody who has a family history of prostate cancer or breast cancer or ovarian cancer in the family. These are reasons to talk to your doctor about genetic counseling. And the reason that that would be important is that if there is the discovery of a BRCA1 or 2 mutation, it would certainly argue that that person should get PSA screening regularly, starting at age 50 at least, at a minimum.
Great. So the big takeaway from this is if you're over 50 or 50 or above, really, then you should begin talking with your doctor about the possibility of screening and what risks may be associated with just your family genetics.
Exactly.
Okay. Cool. Well, switching gears to just maybe talking about some ways to treat the cancer. Are there any new or novel therapies that have been discovered or developed in recent years?
There have been. So the difficult part about prostate cancer is it's a very common cancer. But the blessing of having a lot of patients that unfortunately have this type of cancer is that we have a lot of research that has been done in this field, and we have a multitude of therapies in this field. And in particular, there are a few new exciting therapies that we have that I can focus in on. So the first thing that we've discovered over the last several years ties into our earlier conversation about BRCA1 and BRCA2 mutations. We've discovered that a portion of even patients with advanced prostate cancer have tumors that have mutations in how DNA is repaired. This constitutes about 20% of patients with metastatic prostate cancer. And these are patients that are resistant to our typical hormonal therapy for advanced prostate cancer. And these mutations can be acquired mutations, which means that the tumor developed them over time, or hereditary, meaning they ran in the family and the patient was born with a predisposition to developing this type of cancer. Whether it was an inherited mutation or a developed mutation, we have new treatments called PARP inhibitors, and these drugs target these mutations. And for patients that have these mutations, this is a new treatment option that has been very active and has been better than chemotherapy, better than some of the other oral therapies we have. So this is a huge new treatment for a subset of patients. The second really exciting advance that we've had in the last couple of years has been a completely different type of treatment for prostate cancer. So this type of treatment involves conjugating a radioactive isotope called lutetium with a molecule called PSMA. PSMA is highly expressed in prostate cancer. And so this radioligand therapy is given intravenously to patients. The lutetium PSMA combination goes to all the prostate cancer cells that express PSMA and delivers just a tiny bit of focused radiation to those prostate cancer cells everywhere that they are in the body. This has recently been FDA approved in the last year because in clinical trials has been shown to be very effective in comparison to chemotherapy as well as oral therapies that we have, and we've seen some very dramatic responses with this treatment. The challenge is that this drug is currently having issues with production of the treatment, so we are a little delayed nationwide in getting access to this drug, but it's going to be a real game changer for patients once it becomes more widely available.
Well, and that sounds like it hones in exactly where it needs to go. And does that make it safer? May not be the best word to use, but because it's not maybe necessarily affecting the entire body, is that maybe more beneficial to the patient to receive this type of therapy?
Yes, we believe so. And, if we tried to focus radiation at all those little spots that are unfortunately involved with the prostate cancer when it's more advanced, we could not do that without severe toxicity for patients. But with this approach where you're going inside the body with these very small molecules that are targeted, you get around the issue with toxicity.
Well, that's exciting. And then you also mentioned clinical trials. And because we're a comprehensive cancer center, we have the ability to conduct all sorts of clinical trials. Well, cancer clinical trials is what we're going to talk about, but and specifically phase 1 trials. So are there any additional trials that are maybe available for patients, phase 1 or others that are available for the prostate cancer patients?
Yes, so we are a comprehensive cancer center, and we have a very active research group in the genitourinary malignancy field. So we do a lot of prostate cancer research here at UC Davis, and we're engaged in a lot of clinical trials. And the nice thing is we're involved in trials across the spectrum of prostate cancer, meaning whether the prostate cancer is diagnosed at an earlier stage or at an advanced or metastatic stage. So we have some very interesting non-interventional trials that just look at new imaging techniques that we're using to better identify how advanced a prostate cancer is when it's first diagnosed. So this is looking at patients who have an elevated PSA are diagnosed with prostate cancer by biopsy, and now we need to figure out if it's just stayed in the prostate or not. So there are trials that are looking at new imaging techniques for that. We have trials that are going on with our radiation oncology group, as well as with our surgeons, for patients that are candidates for definitive treatment, which means that their cancer is still confined to the prostate. Some of those techniques involve changing the doses of radiation that we're delivering to see if that can improve the benefit of radiation. Others are looking at addition of treatments that we usually reserve for more advanced prostate cancer. These are oral therapies that we add on top of radiation therapy and hormonal therapy to try to improve outcomes. And this is all geared at trying to prevent the cancer from coming back and prevent the cancer from spreading to new locations. Similarly, on the surgical side of things, we're doing trials where we treat patients with drugs to try to get them the best outcome from their surgery. So they receive treatments based on trials that we have running, and if our hope is that they will have a good response when they get surgery, and again have a low chance of that cancer coming back after surgery. In the more advanced setting, in newly diagnosed metastatic prostate cancer, we have a trial looking at whether it's beneficial or not to treat the primary prostate cancer. Usually when cancer is more advanced or metastatic, we don't try to do surgery or radiation to the original site of the tumor because our belief is that the train has left the station, unfortunately, and the cancer has become too advanced. But there are some data that suggest with prostate cancer, there's still a benefit to treating the prostate itself. And so we have a trial that's evaluating the utility of that in metastatic prostate cancer. And we have a number of trials that are looking in the more resistant setting in terms of benefit. There are a number of experimental trials that we're working on here at UC Davis. So we have a lot of different options for patients that are getting chemotherapy with metastatic castration-resistant prostate cancer. We have a trial that's looking at chemotherapy compared to chemotherapy plus a new drug. So that's an exciting evaluation that we're looking at. And then finally, we have a trial that's looking at a type of treatment called radium. Radium is a type of radioactive isotope as well, similar to the lutetium that we talked about earlier, but radium only travels to bony sites of metastases. So it's really for patients that have cancer that's only spread to the bone. Now, we've had that treatment for a long time, but we're now involved in a trial that's looking at whether combining that with a drug that is called a PARP inhibitor that changes the way that DNA is repaired may actually make the radium work better. So we're also engaged in a trial for that. So our patients with prostate cancer have a lot of different options, regardless of what stage of disease that they have when they come to UC Davis for care.
What's the best way for a patient to engage in a conversation with their oncologist about clinical trials? Is it just something they bring up? Do you bring it up? How does that work?
Well, at a comprehensive cancer center, it's our obligation and our firm belief that patients benefit from clinical trials. So we certainly do bring it up with patients whenever possible. But I think it's always important for patients to be empowered for their own care. And so regardless of the setting, it's always important for patients to ask their oncologists about clinical trials, whether they're available at their institution or institutions nearby. For example, I collaborate a lot with other researchers at UCSF and Stanford and City of Hope and everywhere in California. So when there's an interesting trial that's available at other institutions, I do discuss that with patients if we don't have something that's available here. But that's also something patients can ask their oncologists if they don't like the trials that are being offered at the institution, or if there just isn't one. It's always important to ask if there's another institution nearby that has something that we may not have.
Outstanding. Well, are there any areas of research that you are actively involved in that you'd like to highlight for us?
Sure. So I'm involved in research that focuses on how cells repair DNA and how cancer cells use those mechanisms to proliferate. So as a result of that research, I'm currently the principal investigator of a trial evaluating the combination of a drug called elimisertib, which inhibits a receptor called ATR, which is involved in how cancer cells repair themselves, or any cells repair themselves. And so we're looking at this combination of elimisertib with a chemotherapy drug called cisplatin to see if it can be given safely and if it might enhance the activity of chemotherapy. So that is a phase 1 study for patients with lots of different types of tumors, including prostate cancer. And then I am working in collaboration with one of our fantastic urologists, Dr. Evans at UC Davis. And we're on the verge of activating a trial that's really exciting. That's going to tailor therapy for prostate cancer based on their genomic characteristics. So this study is in collaboration with the University of British Columbia, and it's going to enroll patients that have localized high volume prostate cancer that's high risk of recurring. So these patients, when they go to surgery, they have a very high risk of the cancer coming back. So in this study, what's going to happen is that before patients undergo surgery, they will start to receive hormonal therapy. And in the meanwhile, their tumor will be tested to evaluate what type of mutations the tumor might carry. Depending on those findings, patients will go on various arms on this trial to get targeted therapies or chemotherapy based on the specific mutations that they have and what we think they'll benefit from the most. Our hope is that this is going to result in more patients having very little tumor at the time of surgery, having very clean margins, and having a lower rate of recurrence after their surgery. So we're very excited about that trial.
Well, and it's awesome to hear about the collaboration that goes on not only between departments at UC Davis, but amongst other institutions throughout the country and even the world as we work to just eradicate cancer and come up with the best treatments possible for our patients.
Absolutely. We cannot do it alone, so we have to work with everyone, and it's a group effort, but also exciting that we're all engaged in this.
Well, are there any other additional topics or points that maybe we haven't brushed on that you want to bring up to our listeners?
I would just emphasize that even though prostate cancer is a common cancer, it is a very treatable cancer. In many cases, it is treatable and curable. But even when prostate cancer has progressed to later metastatic stages, there have been so many advances in therapies and our options, and patients are living longer and better with prostate cancer. So there's a lot of reasons to be hopeful in this disease.
All right. Well, thank you, Dr. Parikh, for joining us today. And we thank you for tuning in and listening. If you'd like to get in touch with us, you can email us directly at beatcancer@ucdavis.edu. Beat Cancer is a production of the UC Davis Comprehensive Cancer Center. For more information on our NCI-designated Comprehensive Cancer Center, please visit health.ucdavis.edu/cancer.